Hi, everybody. Good night or good afternoon. Today we have a special VMR about algorithmic thinking and clinical reasoning in the context of rapid response management. We have as discussants Dr. Vatsal Bhatt and Dr. Pranav Shah. They're gonna present each other.
Okay, awesome. I'll get things started off. Thank you so much, Andrea, for that introduction. So today is actually a very special day for us for three reasons. One, it's MLK Day, and Martin Luther King Jr. is truly a symbol of social justice and community building, and it's just kind of an incredible honor for us to contribute to this medical education community on this special day. So we don't want to take that for granted, and we want to remember him. The second reason is we have the opportunity to really be on our dream platform. We really look up to the Clinical Problem Solvers Medical Education Committee, and we're so inspired by them. And we're just incredibly honored that we get to share our thoughts and kind of our teaching sessions with the CP Solvers community. And the third, and perhaps the most important reason is that this is so special, is that I get to do this episode with my best friend, Pranav. And Pranav, I mean, you'll hear shortly, but he's just an amazing all-rounded personality. He's a master clinician, an expert diagnostician, and just an amazing medical educator and an overall incredible person. I look up to him pretty much every step of the way. He has been able to strike like such a good balance in his professional and personal life. He's a wonderful father to two beautiful kids, wonderful husband, and just an amazing friend and mentor to me. Pranav and I have had a very special journey, and I think we alluded to this earlier. We met when Pranav was working as an academic hospitalist at Penn, and I was finishing up my residency. And then actually looking at his journey, I decided to stay on as an academic hospitalist, and that's kind of my career trajectory. So he has definitely had such a huge influence in my life. At Penn, he actually completed his master's in medical education and developed his interest in clinical reasoning. And he took his talents a couple of months ago to the Medical University of South Carolina, MUSC, where his wife is actually doing pediatric cardiology or fellowship, and that's why he actually moved there. There, he very quickly kind of got involved in teaching clinical reasoning at the UME level with medical students and is working with residents doing the same. We have only known each other for 4 years, but I can truly say that he's like my best friend in life. And that is why this VMR is just so precious for us, because, you know, the two of us as medical educators, as really close friends, are just given this opportunity to talk about algorithmic thinking, clinical reasoning, things that we are very excited about. So thank you once again for this opportunity.
Yeah, Vatsal has a lot of kind words to say, but I am just a normal like human being and like a normal like clinician, and I just love teaching, and I love I think when I first started thinking about cases, I was just like, I don't want to kill people. How could I not kill people? And so I think that's where like I think both Vatsal and my like passions for diagnostic errors and clinical reasons started. We're just like, how can we not make mistakes and save lives? And so Vatsal really brings out the best in me. And I think my favorite quality of him is that he just always goes big. There's nothing small with Vatsal. In med school, he was AOA and Gold Humanism. In residency, he goes on to win like the Senior Teaching Award, which is one of the most prestigious awards at Penn. And then as an attending in his first year, deciding to one-up everyone, winning the best overall like academic educator for residents voted by the residents, and the best like collaborative colleague voted by all of like the collaborative APPs at the hospital, all in his first year as a hospitalist. Vatsal not only goes big as a clinician, but goes big as a friend. For my wife's birthday, him and his wife created an entire Harry Potter escape the room in our basement with like such details that we had to use a black light on like a Marauder's map to even figure out where to go next. And there are golden stitches made out of chocolate on our walls. And like when we went to the bathroom, it was like going into Moaning Myrtle's bathroom. It was insane. But then even more so, he goes big for his patients. There was one family that had so many dietary restrictions, and Vatsal cooks them an entire Indian meal just to give them some food in the hospital. So man, to be able to do something with a guy who just goes big, and then now on this platform, I'm just completely honored and excited. And so just to be able to do things that you love with people you love is, I think, the best part about medicine. And so I'm excited to do this case.
Oh my God, Pranav, you're making me laugh, bro. Thank you so much for those kind words. Yeah, that's, oh, yeah, I don't have words. We can get started, guys. We
Yeah.
could keep going on and on about each other. We can get started, no problem.
Can they share the whiteboard, please? Thank you so much, Seima. So we are going to start with the first aliquot. Mr. CP is a 49-year-old male with a history of oropharyngeal squamous cell cancer of the neck, who is admitted for an expedited PEG placement due to difficulty with nutritional intake due to thick corpus secretions, which found passed out near the bathroom when going to urinate. A rapid response is called for syncope and hypotension.
Yeah, so this is great. I will be the first to tell you that I've had so many instances where we get a call from a nurse or a call from a tech or somebody where they're like, hey, patient went to the bathroom and passed out. And so many times it's so easy to just be like, oh, they were urinating, vasovagal syncope, done deal. Let's just get them back into bed. Let's get a set of vitals. And, at that point, I think that that's where the fruitfulness of having a system to evaluate what's actually going on and to address a lot of can't misses is really important. I think the things that really stick out to me in this first aliquot of information is two things. One is that this patient had hypotension. Exactly. Sorry, the chat's popping up too. The patient had hypotension and the nurse thought it was that severe that a rapid response was called. So in my mind, if the nurse thinks this is important, I think it's important. And at that point, I'm like, oh man, I need to lay eyes on this patient and I need to get there. And so, I think the really first thing to think about is when a rapid response is called, what exactly is a rapid response and why is it important that it's called in the first place? And so in my mind, a rapid response is just an acute decompensation of an illness that can be life-threatening, right? It is time-dependent, quick thinking with a very limited amount of information, just like in this case, where we have a fairly young individual with head and neck cancer coming in for an elective PEG tube, now passing out in the restroom, right? As you guys know from all the clinical problem solvers frameworks, you could say, okay, well, let's just think about syncope to begin with, right? So when we think about just syncope, we might think this is orthostatic. We could think this is reflexive or vasovagal. We could think this is a neurologic mimicker, or the big bucket that I really don't want to miss is cardiogenic, right? And so when I think about the physiology, I'm thinking, okay, is there some kind of true hypoperfusion of the brain? And is that hypoperfusion affecting not just the brain, but other organs in the body? Where is this hyperperfusion coming from? Is it coming from a systemic issue, a cardiac issue, an obstructive issue, a hypoxic issue? I have no idea. But the thing is that I want to have a way of thinking when I approach this patient. And so I think for today on Clinical Problem Solvers, we have a unique experience to where Vatsal and I are going to kind of take you through our way of having an algorithmic approach to these common decompensations. So why is this important? Why should we have an algorithmic approach? The reason is because if you just use your system one thinking, and system one thinking, for those who may not know, is your quick, rapid response. It's your quick, just off the tip of my tongue, first thought that comes to my mind, pass through response to a situation. It's what I like to call the ER doc perspective, right? They see a patient in the ER with very limited information. What does their gut tell them? And then system two thinking is kind of your gears churning. You sit down, you're let me really think about this. What's my framework? What could I be missing? What are my biases? And just like a lot of time. In a rapid response scenario, you don't have time, unfortunately, to do a full systems to thinking process. And so what an algorithm does is it takes that system to thinking, which we're doing right now together, and it helps us create a framework or like a way to an algorithm to go through to then do system one thinking in a situation where time is not on our hands, right? So instead of being like, oh, this patient may have had orthostatic hypotension or vasovagal syncope, I can say that, okay, do I have an algorithm for how I look at syncope? Do I have an algorithm for how I look at hypotension? Which one am I really worried about? Which one do I need to address right now, right? And which one is like the most important? I can say I have frameworks all day, but if I have an algorithmic approach, I can then prevent myself from missing certain just can't miss diagnoses and certain high mortality illnesses. So that being said, I do want to put a little caveat to this, is that algorithmic thinking is not 100% all-encompassing thinking. Okay, it is a way. You cannot show up at the bedside with Robbins and Harrisons and be like, okay, I'm going to figure this out with all the information in the world. No, it's, hey, I'm going to come to this bedside like this patient should not have, I cannot miss an MI right now. If this patient had a myocardial heart attack, I cannot miss that, right? If they had a tension pneumo, if they had a, if they're in VFib currently, right? When I go there, if they don't have pulses when I show up there, these are things I just cannot miss. And so I need to, I need to be able, a way to strip my mind of these biases where I'm just like, oh, maybe it's vasovagal or maybe it's orthostatic, and start to think about, okay, what do I need to make sure it's not before I kind of head that way? And so Vatsal and I have created this like beautiful way to kind of think about this. And this is how we're going to kind of talk about our algorithmic approach to these rapid responses. And so I'm going to let Dr. Bhatt talk a little bit about the different parts of this algorithmic approach.
First of all, Dr. Shah, that was an excellent start to our case. That was so fantastic and such a good summary and great way to think about syncope, honestly. So guys, exactly like Pranav was mentioning, you know, rapid response is kind of, it's happening. There's a lot of chaos happening in real time. And there's, unfortunately, time is not on our side to say, pause and think about this. So what we do is do the thinking ahead of time so that when we go into these rapid responses, we can activate things that we have already thought about. So most of rapid responses will have a theme, right? It's typically triggered by either a vital sign abnormality, in this case, hypotension, or by an abrupt clinical change or a change in patient's mental status or a physical exam finding that is really concerning, right? And very common reasons include things like hypotension, respiratory distress, altered mental status, unstable arrhythmia like tachy or bradyarrhythmia, or seizures, bleeding, stroke alert, right? So there's like a finite amount of situations, 90% of the times, where we actually know that these are the things that are going to trigger rapid responses. And the reason why we mention this is because we can actually create algorithms for each of these ahead of time in the background so that when these particular rapids are called, we know which kind of thinking to activate. So algorithmic thinking, as Pranav mentioned, is a problem-solving tool, really, that allows us to take a very complex situation and approach it very methodically to ensure nothing is missed. And in medicine, algorithmic thinking basically allows us to plan, right, for an unexpected event and critically approach it. So there are four major parts, guys, to algorithmic thinking. The first part is decomposition. So breaking down a very complex problem to smaller parts, right? Taking a complex situation and just boiling it out to little parts as you're creating your algorithm. So the second is pattern recognition. So looking for similarities in things. The third one is abstraction. So focusing on the most important information only. When there's chaos around you, how do you pick and choose what is noise and what is actually what we need to focus on? And the last thing is really the algorithm, developing a very step-by-step solution to the problem, right? And why is this important? It's important because we want to make sure things are not missed. It increases our comfort level in an uncomfortable situation, and we can think through things quickly in a rapidly evolving situation. The most important thing to remember, guys, is there's no one right algorithm in medicine, right? The importance is thinking about having an algorithm so that when you're in a high stress situation, you can quickly think through a problem without missing any major things. So let's actually go ahead and create an algorithm together about running a rapid response, right? So rapid response 101, this patient is about to have a rapid. What would an algorithm for a rapid look like? For example, number one, 10-step approach, okay? Number one, appearance of the patient is key. So when you go in, just an eyeball test can give you an idea of where they are on the spectrum. Do they have a pulse? Are they breathing? Are they in obvious respiratory distress? Or are they a little bit stable that you have a little bit of time, right? So gauging that is going to be step one. Step two is vital signs and access. I like to say IV O2 monitor, right? So making sure that access is established, oxygen is delivered if needed, and they're hooked up to the monitor should be step number two. And constant cycling of vital signs. Number three is assessing. So summary of a clinical situation, who is present in the room, where, like what exactly is happening in the room, and what needs to happen in the immediate next steps. Number four is going to be assigning roles. So you're going to be standing at the head of the bed and commanding the room and just really assigning who is going to be doing what. Number five is communication. Remember, speaking loudly, clearly, and perhaps the most important, closed loop communication. So instead of saying like things like, hey, you go get an ABG, just actually say, look at someone, address them by their name and say, can you please get an ABG? And they should ideally repeat, I will be getting an ABG. Number six, getting help, right? So if you actually need more people in the room, like senior physicians or senior medicine residents for our junior residents, or critical care team, or respiratory therapists, or anesthesia, or surgery, getting the troop mobilized early on is going to be very useful. Then you're going to do examining. Right? So it's going to be a very hypothesis-driven exam. And we'll talk about that for hypotension in just a bit. Number 8 is going to be gathering information. So having a colleague just look at the data and get like a background history while you're focusing on the patient themselves. Number 9 is going to be stabilizing, right? So following ABC, making sure that the patient is stable. So airway, breathing, circulation. And number 10, finally, is going to be transitioning. So assigning someone kind of the task of coordinating an ICU transfer, higher level of care, or coming back and making sure that you are reassessing the patient if the rapid response is over. So this 10-step algorithm is just an algorithm that is created for running rapid responses 101. So any rapids scenario, you can, if you remember these 10 steps, you will remember, hey, we need to make sure IV access is established. We need to make sure the patient's hooked onto the monitor. The basic steps that are very important will not be forgotten. So this is just an example of an algorithm just for rapid response. Let's actually take a look at the next steps and see what else we can do as we hear more about the story now.
Yeah, and just again, I just want to add one like key component here is that when you guys were thinking algorithmic clinical reasoning or algorithmic approach, we always just think diagnostic. But therapeutic is just as important. And so this is really a therapeutic algorithm to be like, okay, how can I feel supported? How can I feel comfortable in an uncomfortable situation? And how can I know who's in my surroundings, who are the people, who are the players that are helping me in this like situation, what things do I need to do? So you have kind of two different algorithms that are going to run parallel as we handle this case. One, the therapeutic algorithm, which Dr. Bhatt beautifully went over. And the second will be the underlying diagnostic algorithm, which we'll kind of talk about as we get more information. So Andrea, can we have the next aliquot of information?
Sure. The patient has been suffering from oropharyngeal squamous cell cancer for a year and has had 34 fractions of radiation for his cancer. He has had adenophagia, and now due to the radiation, he has suffered from severe esophagitis, which has led him to have thick, copious secretions that he has a difficult time clearing. Despite glycopyrrolate therapy, he continues to bring up these copious secretions and is not able to take in much nutritional intake. Therefore, his oncologist sent him for an expedited PIG placement to optimize his nutritional status so he can get started on chemotherapy. On admission, he had no complaints except for his secretions really bothering him. He had denied any chest pain, shortness of breath, nausea, vomiting, fevers, chills. He didn't complain that he was not able to completely empty his bladder today, but he wanted to try on his own without having to get straight catheterization. The nurse tells you that shortly before you had arrived for the rapid response, a loud toot was heard when he had gone to urinate. He's found down on the bathroom floor, moaning and barely responsive. His vitals currently include blood pressure 79/53, pulse 103, temperature 100.3, respirations 22, oxygen saturation 82 on room air taken by the nurse.
Wow. So a ton of information. Thank you so much, Andrea. In this case so far. And so, man, I have like information overload. So just to summarize a little bit, we have this like middle-aged man. He has head and neck cancer. He's gone through some radiation therapy. He's on glycopyrrolate therapy. And he for his like copious secretions, which he's also having, and he is here for a PEG tube because he has poor nutritional status. I'm guessing, given his active chemotherapy, he probably has like decreased energy, decreased functional status as well, maybe functional movement. When he falls down, there's like this like thud that's heard while he was urinating. Okay, so again, my biases pop straight up. So I'm like, oh man, syncopal episode while he's urinating. This is vasovagal until proven otherwise, or orthostatic essentially until proven otherwise. However, the things that don't really fit for me is, why is he persistently hypotension still at this point? He's 79/53, I think, and his pulse was 103. At this point, I'm trying to think, okay, hypotension. Do I have an algorithm to think about hypotension? Is hypotension, what are the factors that are kind of sending me in different ways for his hypotension? Is this distributive? Is this cardiogenic? Is this obstructive? I'm not quite sure. His pulse is 103, his temperature is 100.3, not quite a true fever yet. He's a little bit tachycardic. His respiratory rate's above 20 at 22, and I'm getting that he has some confusion or altered mental status. So if I just look at his Q-SOFA, we're already Q-SOFA 3 out of 3. Do I think this is sepsis? Am I missing something here, right? Or do I still think that, hey, this is clearly vasovagal syncope? Or is there something else I'm totally missing altogether? Is this cardiogenic shock? Is this obstructive shock that I'm also missing? And so, again, I have all this information, but I have no way to synthesize all the information. How do I go about evaluating this patient? And so at this point in my mind, hypotension is like the big thing I need to fix right away. I fix hypotension, I increase systemic volume. I should increase then, hopefully, cerebral perfusion at this point. So, Dr. Bhatt, is there a way, or can we use our approach now to have an algorithmic approach for diagnostics in this patient's hypotension?
Yeah, absolutely. Wow, that was a lot of valuable information. And Dr. Shah, thank you for getting us started. That was like so great. So guys, whenever we're trying to create an algorithm for, let's say for hypotension, right? We really need to get a hold of the players, right? So right now I'm on my way to the room and I'm trying to figure out what players am I going to look for and activate when I'm inside the room, right? And so having an idea of that is going to be very important. So what I'm really asking is, what are clues that this patient is approaching shock type pathophysiology? Am I worried that this patient is in shock because of the hypotension, right? And shock is nothing but end organ hypoperfusion that leads to some sort of end organ damage, right? So when we say hypotension, really the question shifts a little bit to saying, what is my MAP or mean arterial perfusion, right? And the magic number is 65. Why? Because mean arterial pressure is nothing but systolic blood pressure plus 2 times diastolic divided by 3, right? And multiple validated studies have suggested that when the MAP is less than 65, you have evidence of end organ damage. whether it be CNS damage by altered mental status, whether it be renal damage by AKI, whether it be liver damage by shock liver, and so on and so forth, right? So map is going to be key. So when I'm entering in, I'm thinking I'm going to have to look at the monitor and I'm going to have to see what the map is. The next clue is urine output, right, guys? So urine output is a marker of end organ damage for kidney. So I'm going to really pay very careful attention to what the urine output has been for the duration of the day, right? And remember, urine output below 0.5 cc per kg per hour should get us concerned that this patient is hypoperfusing the kidney. Then comes mental status, right? Really, mental status is going to give us so much valuable information, because if the patient is altered, confused, or like not with it, that is a sign of cerebral hypoperfusion. So I'm going to be looking for that. I'm going to be also looking for pulse pressure. So systolic over diastolic, if you take the subtraction of it, if the pulse pressure is super wide or super narrow, that is going to be indicative of certain types of shock that Dr. Shah alluded to, right? The next thing is skin perfusion. So I'm going to look at a quick skin exam, because skin exam is going to help me decide whether this is distributive shock if there's warm and flush skin, or cardiogenic shock if it's cool and clammy skin. Finally, I'm going to look at a shock index. Shock index is heart rate divided by systolic blood pressure. If the shock index is greater than 1, it could be suggestive of shock. Remember, it's just one of the many players. So if you have a young woman who's coming in with pyelonephritis, they may be tachycardic and the systolic may be very low, just at baseline, and their shock index automatically is greater than 1, but they might not necessarily be in shock. So it's just one parameter you can use along with many. And then the last player really is a lactate, right? Because an elevated lactate is a sign of hypoperfusion. But remember, a normal lactate will not completely rule out shock, because the body takes a little bit of time to catch up. So if there is a normal lactate, don't get fooled. But at the same time, if your lactate is elevated, that is definitely a sign that this patient is in shock. So how are we going to overlay some of this algorithms? So what I would do personally is try to overlay the rapid response 101 algorithm with the hypotension algorithm. What do I mean? En route, ask for a full set of vitals. When you get there, appearance of the patient is a key. Recheck blood pressure with proper technique and establish access and place the patient on monitor. Read the room, assign roles, command control of the room, and use closed-loop communication. Will you need any other help? Call RT, procedural expert, ICU team, or anesthesia if you need. Perform a very quick and thorough hypothesis-driven physical exam. In this case, I would do a skin exam, mentation exam, and a volume status exam. Then I'm going to start to formulate a quick differential, kind of like Dr. Shah said, which type of shock am I dealing with, to facilitate the discussion of what next steps should look like. And then I'm going to focus on stabilizing the patient, right? Performing the appropriate interventions in a timely manner. In this case, does this patient need fluids? How often does it need fluids? In what setting, like how much fluids am I going to deliver over what time, right? And then you have to escalate care appropriately. So once we get the physical exam, including the vitals and the physical exam, I think we can get a little bit more information about where to go next with the shock. So Andrea, if you don't mind sharing the next aliquot, I think that would be helpful.
Sure. So then we will start with the physical exam at the bedside. Blood pressure was 79/53, pulse 103, temperature 100, respirations 22, height 5 feet 7 inches, 1.702 meters, weight 165 pounds, 1.6 ounce, that is like 64.9 kilograms. Oxygen saturation was 96%. NRB and BMI was 25.86. In general, the patient appeared confused, moaning, lying on the floor, hoarse voice due to radiation. In the hand, he was normocephalic, atraumatic, neck has area of erythema from radiation, cardiovascular, tachycardic, regular rhythm, respiratory, decreased breath sounds at the bases bilaterally on NRB, no apparent respiratory distress. Abdomen, bowel sounds present, soft, non-distended, non-tender, musculoskeletal, no peripheral edema, no swelling, no tenderness to palpation, full range of motion, skin warm and dry, alert and oriented times to person and place, confused and slow to respond, lethargic appearance, and no focal neuroexams, and cranial nerves were closely intact. In psychiatry, behavior and responses were slow. The lab from this morning was sodium 134, chlorine 100, bang 18, glucose 115, potassium 4.8, CO2 24, creatinine 1.1, hemoglobin 9.8, hematocrit 30, white blood cells 12, platelets 282. His INR was 1.4, and his LFTs were unremarkable.
Okay, man, tons of information here as well. So let's just start with quick. My system one thinking is activated at this point. This patient is hypotensive with decreased cerebral perfusion when I'm first seeing him. Now I'm thinking, okay, so there might be some kind of shock component. So now what am I looking at, right? And so we look at, we get a HENT exam, and we see that he has some hoarseness of his voice. My question is, does he have stridor? Is this anaphylaxis? Is this some kind of allergic response? Is he having obstruction from that perspective that's causing hypoxia and maybe, again, a syncopal episode, hypotension, shock? Possibly. He does have erythema around his neck. Is that related to cellulitis? Does he have some kind of oropharyngeal abscess, given he's getting radiation therapy to his head and neck cancer? Is there some kind of infection that's brewing there? The thing that's really bothering, his cardiovascular exam is actually very reassuring for me. I didn't see a JVD on that physical exam, and nor does he have any extra heart sounds, no S3. So I think that, cardiogenic shock is really, really much lower on my differential at this point. And then his lung exam is also super concerning to me. This guy is on a non-rebreather at this point, a non-rebreather saturating 96%. He's stable, but I'm not on a non-rebreather. That's not okay. And so he has decreased breath sounds bilaterally, concerning for some kind of lung pathology or some kind of hypoxia due to, I'm not quite sure yet. Is it due to hypoperfusion, or is the hypoxia causing the shock from an obstructive fashion? The rest of his exam, I think for me, is just really pertinent that he doesn't have swelling. He doesn't have any signs of kind of cardiogenic shock, which for me is great, because I'm like, okay, fluids. And I don't need to kind of worry from that perspective. That I might volume overload him. And then finally, what I really like is the labs. The labs from this morning, which I'm guessing are before the shock, before his current picture of where we're seeing him during a rapid response, shows a normal creatinine of 1.1. This tells me that he was perfusing his kidneys earlier today, and now he may not be, right? And so this is a very acute rapid response here, very acute hypoperfusion. And so that really helps me differentiate a lot of the thought processes in my mind. And I think will help us come up with a great algorithm for undifferentiated shock. So Dr. Bhatt, do we have any way to put all this information into a nice algorithm?
We do. Guys, that was excellent, Pranav. I loved how you took the physical exam and the labs from this morning and really painted a clinical picture of where we are, giving your differential in the process. That was awesome. So guys, what we're really worried about here, the thing that stands out to me and the thing that I'm worried most about is his hypotension, right? Because at the end of the day, if your perfusion is compromised, all your other organs can be compromised. So what I'm going to really deal with first is going to be the hypotension. And then I'm going to worry about the other things, right? At least he's satting 96 to 97% on non-rebreather. I am still worried about his respiratory status, but I really need to work on his hypotension. So before we do create an algorithm for undifferentiated shock, we need to understand what shock is, right? So the basics of shock can be summarized by one cardinal equation. And that cardinal equation, I could argue, summarizes all of medicine. And that equation is nothing but mean arterial pressure is equal to cardiac output times SVR, systemic vascular resistance, right? Cardiac output in turn is made up of heart rate times stroke volume. Stroke volume in terms of is made up of preload, afterload, contractility. Why do I share this equation? Because any break in any of these parameters leads to a compromise in MAP, right? So let's review that, right? If you have a break in cardiac output, let's talk about the first break, which is preload, right? So if you have a break in preload, you can have two different types of shocks. The first one is easy to understand, which is hypovolemic shock, right? So think about your Ds: dehydration, diuresis, diarrhea, bleeding, sorry for the cheating, but like things along those lines, anything that is leading to low volume in your circulation is going to lead to hypovolemic shock. That's a preload problem, ultimately a cardiac output problem. We know that type of shock. Second type of shock with preload is an obstructive shock. Guys, obstructive shock is made up of two different parameters, left-sided and right-sided. What I'm saying is left ventricle underfilling, right ventricle underfilling. The right ventricle is affected by two different parameters. The first one is tension pneumothorax, and the second one is cardiac tamponade. If you guys remember Beck's triad, right? Muffled heart sounds, elevated JVD, and hypotension leads to underfilling of the right ventricle and in turn a collapse in your hemodynamics, right? So that's right-sided circulation. The left-sided obstruction is usually a PE, pulmonary embolism, because between the right and left side sits your pulmonary artery. If it's clotted, you're going to have clot that is going to be manifested in compromise in your left ventricle, right? Left circulation. So those can lead to obstructive shock. The cardiogenic shock is easy to understand if you understand afterload and contractility. If you have an increase in afterload or a reduced contractility, you will have cardiogenic shock, which I think Dr. Shah very nicely mentioned may not be going on here. The last type of shock really is distributive shock, right? And distributive shock has so many different components, guys. So one is septic shock, which we always think about, right? Anytime we have someone who we're suspecting distributive shock, the thing that comes to our mind is septic shock. But let's not forget some of the other ones. So the other one is anaphylaxis. Another one could be anesthesia, adrenal crisis, spinal trauma, or things like acute liver failure, right? Those are all types of distributive shock that can lead to hemodynamic compromise. And knowing what type of shock you're dealing with can help you with the intervention that you want to do. So with all of that in mind, let's actually create an algorithm for undifferentiated shock. So in this patient, I'm going to go in. The first step in my algorithm is this truly hypotension? So I'm going to check my manual BP just to make sure it is. Let's assume it is. The second step is going to be, is this hypotension related to arrhythmia? Remember when we said cardiac output is a component, which a component of cardiac output is heart rate times stroke volume, right? If your heart rate is affected, aka tachycardia or bradycardia, it can cause you to have hemodynamic compromise causing hypotension. If that is the case, you may have to cardiovert or you may have to pace depending on the situation you're in. I don't think that's going on here, given the heart rate is 103. We don't have an EKG yet, but if I had to give a hunch, that's probably not what's going on. Third thing, is this hypotension related to anaphylaxis? Do they have steroid exposure? Are they having stridor? Are they having facial swelling, tongue swelling, difficulty talking? Based on just the preliminary exam, it doesn't sound like it, but if it was, you have to give epi, steroids, and antihistamines. Then you're going to ask yourself the next question on step number 4. Is this acute cardiogenic shock from an acute MI? This patient is not having acute chest pain. It's not behaving like an MI, but an EKG would help. If that is the case, you have to start pressors and get them to stat cath lab, like immediately. Then you're going to ask, do I have any concerns for adrenal crisis, steroid exposure in the past leading to adrenal crisis? If that is the case, you have to give stress dose steroids. I don't know if this patient is on steroids or not, but that's just something in the back of my mind. Then comes the question, can this be obstructive shock? Can this be tension pneumothorax, PE, or cardiac tamponade? I don't think this sounds like tamponade. This doesn't sound like tension pneumothorax, especially with lack of breath sounds on one side or anything like that. But a PE is certainly on the differential in this patient who has malignancy, who is passed out and has respiratory distress, right? And then the last thing, which is a bucket that 90% of the times we're left with when we're dealing with shock rapid response is this primarily cardiac output mediated aka cardiogenic shock, or is this SVR mediated, aka distributive shock? And for this, you're going to check pulse pressure, skin exam, mentation, and consider doing an ultrasound guided IVC exam. Now, POCUS is becoming much more prevalent. Things like an IVC exam, a bedside heart exam, bedside lung exam can give very valuable information. So this is just kind of a quick 7-step approach to an undifferentiated shock. And the purpose is you will make sure to think about every differential on the evaluation of an undifferentiated shock. So that's the purpose of creating this algorithm.
I love that, Vatsal. Very, very much geared to, hey, let's not anchor. Let's not have our biases lit up. Let's not just think this is vasovagal. Let's make sure it's not any of the other causes of shock. So let's go through an algorithmic approach to make sure that we're not missing any of these big life-threatening illnesses or like high morbidity diagnoses that could kill this patient. And so it's really important to kind of have an algorithmic approach. It just stops me from just anchoring and framing it in a way where I'm like, oh, middle-aged man was emptied his bladder, passed out. Obviously, this is vasovagal. It's so easy to do. And so this having an algorithm really takes you out of your comfort zone, takes you out of that like that mindset. And it's like, okay, let's go through a checklist. Let's make sure we're not missing anything. Andrea, let's keep moving on to the next alquat.
Sure. After 3 liters of fluids, the patient's blood pressure improved to 100/80. His mentation has also improved, and he's wondering what happened. He continues to require 6 liters of oxygen and is saturated 93%. He's not in any obvious respiratory distress. The rapid response team is figuring out what the next step should be now that his hypotension has improved. The home medications, he had prednisone 3 milligrams daily, atorvastatin 80 milligrams daily, glycopyrrolato 1 milligram each 6 hours, PRN, metformin 500 milligrams daily, oxycodone 10 milligrams each 6 hours, duloxetine 30 milligrams, and levothyroxine 75 micrograms. Allergies, no. Past medical history, diabetes mellitus, HLD, oropharyngeal squamous cell carcinoma, anxiety, and hypothyroidism. Past surgical history, no. Social history, 20-year smoking history, quit at the time of diagnosis 1 year ago. Used to be an occasional drinker, quit at the time of cancer diagnosis 1 year ago. Lives at home with wife and his 2 kids. In family history is not contributory, no family history of any other malignancies. In the review system, pertinent items are noted in the HPI. Comprehensive review was negative. Lactate was 4.7, and his EKG showed sinus tachycardia 105. No ischemic changes.
Oh man, tons of information here too. And so for the sake of, I think time, I'm gonna kind of think about this a little bit quicker than I'm used to, but really when evaluating these cases, I need to ask myself at this point is what does it fit? Because clearly this patient came in for a peg tube placement and now he's hypoxic to 6 liters, right? He is in shock as well. So hypoxia and shock are kind of my 2 big diagnoses here, and everything else, all of this other information is really cluttering the way I'm thinking about this patient. Is he on, medications that could cause urinary retention? Is that what's like leading to a lot of his issues? Is it his cancer history? Is it his smoking history? Does he have emphysema or COPD? Now it's in an acute flare because of his because of like the current shock. These all seem to could be contributing, but I feel like they're distracting me from the things that are very acute. This patient is in a rapid response, right? And so at this point, I have stabilized his hypotension. We have given him fluids. His blood pressure looks a little bit better. However, he's still on 6 liters of oxygen, and I need to now figure out how to address this. And so before we kind of go into addressing that, what I do want to talk about is the biases that have come to my mind throughout this case so far. So just reflecting quickly, did I frame this patient in the wrong way when I was first thinking about him? 49-year-old found to have syncope while using the restroom. Is this vasovagal? Did I anchor heavily in the beginning? Maybe I'm saying, oh, this patient had difficulty urinating, finally voided his bladder shortly after he passed out. Vagal event. Oh, but now he's hypoxic. Maybe it's because of his thick secretions. He must have had an aspiration event, or maybe he mucus plugged. Is this some kind of search satisfying or like eureka diagnosis where like, oh, you know what? This patient had a vagal event, mucus plug. Now he's improving with fluids. Likely he aspirated when he like passed out. These are all biases that are coming to my mind. And what would be helpful is if I had some kind of algorithmic approach to kind of move away from anchoring, from search satisfying, and from framing. And so some of the tools we can use are things like a diagnostic. This patient is hypoxic now. He has acute hypoxia. Wasn't on oxygen before this event, now is on oxygen. Second, is there a checklist I can use? Maybe a diagnostic error checklist. So what are my can't miss diagnoses here? MI, definitely. PE, definitely. Did I just accept the first diagnosis that came to my mind? No, I didn't, because I came up with an algorithm to not do that. Are there pieces that don't fit? Yeah. Why is he hypoxic now? He was just he was hypotensive, now he's hypoxic. And was this diagnosis suggested to me? Did somebody else give me a sign out? Am I anchoring on what the nurse told me? Or am I able to actually go through and systematically think about this patient? And so, Dr. Bhatt, is there an algorithm we can use for hypoxia now that this is becoming the leading symptom going forward in this rapid response?
Absolutely. Yeah, of course. Let's talk about hypoxia. But before we do that, one important thing I wanted to kind of mention, just going back in terms of management in a situation like this, rapid response for hypotension, is really, if you did a thorough exam and you found that the patient is not volume overloaded, fluid resuscitation should start early and appropriately. So what do I mean by that? You should pressure bag fluid as fast as you can and run it 999, so wide open. And you want to get fluid as fast as possible to perfuse the patient as much as possible, because hemodynamic compromise can lead to really devastating outcomes. And you can do up to 3 liters of fluids with reassessment in the middle. You can also do a straight leg raise where you just lay the patient flat and just put the leg up and have some of the volume go back. And those are some of the management techniques that can happen. Unfortunately, in this patient, we gave them 3 liters of fluid and the blood pressure did improve. So now we have a little bit of time, but the hypoxia piece is really puzzling and still not making too much sense. So let's talk a little bit about an algorithmic approach to hypoxia. It's a little bit different from hypotension in the sense that for hypoxia, you have to think about diagnostics and therapeutics simultaneously, right? So what you have to do is when you go in, you assess the overall appearance and work of breathing. You do a focused exam, including a lung exam. Are there crackles or wheezes? Skin exam. Are they wet or dry? Do they have lower extremity swelling? And a mental status exam. Fortunately, we have done all 3 of them for this patient during this rapid. Then you have to ask yourself diagnostics. What do I need to get? Every patient with acute hypoxia everyone should get EKG, chest x-ray, and a blood gas. EKG and chest x-ray makes sense because we want to rule out any sort of acute cardiac process and acute pulmonary process. A blood gas can really be helpful, not only for the acid-base status, but also to confirm what we're seeing on the monitor. I mean, pleth is a good example. If you have a good pleth, that could be indicative of a good oxygen saturation, but really in an acute hypoxic situation, you can actually get a lot of valuable information with the blood gas. And then you have to ask yourself, what exactly happened? And then you do approaching oxygen escalation and targeted therapy simultaneously. So in order to ask about what causes acute decompensation or acute hypoxia, we have an approach. And this is partly thanks to our friend and colleague, Dr. Flint Wang at Penn, who has also taught us a little bit about acute hypoxia management. And really the focus is 5 Ps and 5 As, okay? 5 Ps, pneumonia, PE, pneumothorax, pleural effusion, pulmonary edema. In this case, flash pulmonary edema, and 5 As, aspiration, anaphylaxis, atelectasis, asthma/COPD, and ARDS, right? So 5 Ps and 5 As, again, not completely comprehensive, but gets very close to most of the diagnosis. In this particular patient, just looking at 5 Ps and 5 As, the things that I'm thinking about are PE, aspiration, and maybe pulmonary edema, right? And again, the lead thing that I don't want to miss is a PE. Then you have to ask yourself, what is a stepwise approach to oxygen escalation? So everyone starts at step 0, which is room air, right? And again, room air is 21% FiO2, and positioning of the bed is going to be key, because head of the bed all the way upright is going to improve VQ mismatch. Then the first step is going to be having a nasal cannula. Nasal cannula can go up to 6 liters of oxygen, and with every liter increase, you're actually going to see that you can increase the FiO2 by 4%. So if you do a quick mental math, with room air plus increasing 6 liters times 4, 24%, you can actually go up to 45% FiO2. The next step would be to consider something like a non-rebreather. It can give us 100% FiO2 and a wiggle room to think through some other things. But remember that a non-rebreather is always a bridge to something else, okay? The next step would be high flow nasal cannula. It delivers 10 to 60 liters per minute and up to 100% FiO2, and it also gives you a little bit of positive end expiratory pressure, PEEP. But after 50 to 60% of FiO2 on high flow, you have to think about escalating the patient to a higher level of care like an ICU. The next step would be BiPAP. Bi means 2, PAP is pressure, right? So inspiratory and expiratory pressure to keep airways open. You can do this normally at nighttime for hypercapnic respiratory failure or 1 to 2 hours on the floor, but more than that, you really need to send the patient to the ICU. This really works for hypercapnic respiratory failure and acute flash pulmonary edema. And the last step really is intubation or mechanical ventilation to improve both oxygenation and ventilation. But remember, always ask about the code status for the patient before you intubate. So again, the approach for hypoxia, for an algorithmic approach, is going to take into account diagnostics, the P's and A's, and therapeutics, O2 escalation therapy, right? And then you have to do targeted therapy for each of the diagnoses you talked about. So pneumonia gets antibiotics, PE gets anticoagulation or a PE response team, pneumothorax gets decompression, pleural effusion gets diuresis, and so on and so forth, right? Every single one has a targeted therapy assigned to it. So just remembering and creating your own algorithm with the diagnostics and an associated therapeutic and keeping in mind the O2 escalation ladder can really save a lot of mental space when you're approaching this patient with a rapid response.
Absolutely. And again, like we've said, having this algorithmic approach is just because we're thinking about it now. And so when we have a rapid response, we can be like, okay, what are my 5 P's, 5 A's? What do I need to do? ABG, chest X-ray, EKG. Let's get that done now, right? And a chest X-ray will really rule out half of your things, right? Pneumonia, flash pulmonary edema, pneumothorax. You're going to see all of these on just a chest X-ray. Right, so you can really atelectasis, ARDS, like they'll all show up, even aspiration. So like a lot of it will show up on just a chest X-ray. And so just having a framework of thinking, but having like a stepwise way of going is really, really important. And I think the other thing that I did want to talk about is just our algorithms that we're creating. The best algorithms are the ones that you create for yourself. So although we might use 5 P's and 5 A's right now, where's mucus plug? That should have been in there. This patient totally could have mucus plugged.
That's
right?
a nice plug. That's true.
Yeah. And so it's, again, the algorithms are not fully 100% complete, but they just provide you with a way to think through a case in a rapid response scenario. Okay. So I think like from here on, I think I agree with Vatsal in that getting a CTPE, a chest X-ray, ABG, EKG will be super helpful. And so we'd love to get those tests now that we've stabilized this patient on oxygen and their blood pressure.
Yeah, and we're really worried about aspiration event, mucus plugging, and really PE that we don't want to miss. And that's kind of where we're thinking through this problem with hypotension, hypotension that has revolved in acute hypoxia that's still ongoing.
Okay, so I'm gonna read the next aliquot and see. Check chest X-ray, we can see traces of bilateral effusion. There is no focal consolidation or pneumothorax. CT of the head without intravenous contracts showed no acute intracranial hemorrhage or mass effect, and the CT of the chest showed a massive saddle pulmonary embolism with right heart strain. The response team was consulting and they promptly facilitating getting the patient to get catheter-directed embolectomy. He had an urgent mechanical embolectomy with a large amount of thrombus removed from the bilateral pulmonary arteries. RHC after thrombectomy showed stable pressures. He was freely in RV, but we need to run air. He was placed on a heparin drip and then transitioned to therapeutic Lovenox, which the patient preferred over a DOAC given odinophagia with pills. Acute PE precluded the placement of the enteral access given the risk of interrupting anticoagulation in the setting of acute pulmonary embolism with extensive clot burden. A PIC was placed on 4/1 and TPN was started. Patient was discharged home in a stable condition.
Wow. What a humbling case, right? Of a patient who came in for just an elective procedure to get a peg tube placed and was diagnosed with a massive PE, guys. This patient, based on the clinical findings, could have very easily died in his sleep if it wasn't for catching this diagnosis and having this rapid response. And this case really highlights so many important lessons from really the importance of algorithmic thinking in medicine, approaching clinical emergencies in a systematic way, not falling prone to our own biases, formulating algorithms for common clinical emergencies. These are just two algorithms for clinical emergencies that we shared with you guys, but there are other clinical emergencies for which you can create your own algorithms, right? And we want to kind of empower you to really create an algorithm based on your institution that makes sense for you guys so that you can take a photo or a screenshot and store it in your phone. And what you can do with these algorithms is if you are in a situation where there's a clinical emergency, you can quickly, when time is of essence, you can activate literally that algorithm, think through it and not miss something, right? And this will allow us to be prepared when it comes to a very fast-paced dynamic situation where our type 1 thinking is going to override our type 2 thinking, but you'll have already done your type 2 thinking ahead of time. And so that is why we think algorithmic thinking is so important. And I mean, what a very humbling case. I would love to hear your reflection, Pranav.
Yeah, absolutely. I think at the end of the day, we have to remember that if we fail to plan, we plan to fail, right? So especially in cases like this, where we're called about one thing and the first thing comes to our mind might not be the right diagnosis, but that's okay. Because the idea with clinical reasoning and with algorithmic thinking is to just give you a system of stop signs. It's like, hey, did we miss this? Did we miss this? Did we address these things, right? And if we don't have a system of stop signs, we're just going to rush through to the final destination and we might miss our exit. And so we really need just a nice way to slow ourselves down in a rapid response scenario, just enough for us to catch these more subtle, more difficult diagnoses. It's very possible that this patient may have been on long-term prednisone and had actual adrenal insufficiency and went into adrenal crisis. And that's why they were hypotensive. Who knows? But the idea is that, did that thought even come to my mind? Did I have an algorithm to where that thought did come to my mind, right? And so again, the whole idea of an algorithmic approach is to be able to step away from our biases, step away from our gut instinct, our first thought process, and just give ourselves some room to be like, okay, what can't I miss? What things don't fit? Can I go through this in a systematic way and provide both therapeutic algorithms and diagnostic algorithms? So I, myself as a clinician, feel comfortable in an uncomfortable scenario. And so again, just reflecting back is half the battle. Reflect back on the cases that you've had in the past and be like, what could I have done better? How could I have created a flow that may have helped me get to a diagnosis faster, made the right diagnosis, or help the people around me feel comfortable while we're trying to get to the diagnosis? And having an algorithmic approach helps you in all three of those scenarios.
Absolutely. That was a fantastic reflection, Pranav. This was a case I actually had when I was an academic hospitalist year 1 on the floor. And I actually ran this rapid with keeping all these algorithms in mind, because I was really learning about clinical reasoning and algorithmic thinking at that time. And it was truly a very humbling case, because we actually saved this patient's life by thinking through this. So we actually, this exercise was much more about the journey rather than the destination. And just for, I know we're out of time, but I did want to show you the image that, like, we literally looked at this radiology image of this, the CT-PE scan. And before the radiologist called us, we activated the PE response team because it was that obvious. So if you have just 1 second, I would love to share the screen just to show you this image for our reference. Do you mind, Andrea, if I just share the screen?
Yes, go ahead.
Okay, awesome. Okay, share. I don't know if you guys, can you guys see this?
Yes.
Yeah.
But
Okay.
you can put it presentation so it looks bigger.
So, guys, this was the image that we received, and immediately me and like the APP that I was working with, the two of us look at this and we're like, oh my God, we have seen this in textbooks as a definition of saddle PE. Oh my God, we're so concerned. And we just got everything kind of activated. We were not expecting this. We got a CT head and a CT PE while he was just down there. We were saying, hey, this is a mucus plug or an aspiration event, but we don't want to miss PE. That's kind of what Dr. Shah was mentioning. What can't you miss? That's what we wanted to do. And this is, guys, what we took out. We actually called the PE response team, and they took the patient in immediately for catheter-directed embolectomy, and all of that clot burden came out. And so really the beauty and the power of clinical reasoning and algorithmic thinking lies on this, right? Like not missing essential can't miss diagnosis and systematically thinking about things when you're in an evolving, chaotic situation where you just, your mind stops thinking. What do you do in that situation? Algorithmic thinking has helped me, has helped Pranav, and we're really, really hoping that it helps all of you guys as you navigate your journey through medicine. So thank you so much for.
Thank you everybody for coming and listening and participating. Again, it's been such an honor to be here.
That has been an amazing case, and thank you everybody for joining us.
Thank you so much, Andrea, Maddie. Really appreciate your guys' help with all this, and all of the subscribers that I'm watching just like pop up on the screen.
Absolutely. And we're happy to share some of our algorithms that we have created. You guys can post it on Twitter or wherever you like, and hopefully that can empower all of you guys to create your own algorithm and really learn from it, but also teach it to other people and really just share the wealth of knowledge. You know, it's ultimately all about patient care, and I think everyone can benefit from that. So thank you guys once again.
Thank you. Enjoy the rest of your day. Bye.
Thank you. Bye.